Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So today I wanted to talk about an article I came across, and it was interesting. It's in the AMA Journal of Ethics, and it's focusing on something that I'm dealing with in an audit that I'm currently doing with a few colleagues of mine. And thank you, Christine Hall, for sending it over to me. I think it's a great article. And it talks about copying and pasting patient treatment notes. And I know we've always had conversations back and forth about copy paste and clone notes and things like that. But this is just interesting because it comes up in the Journal of Ethics. Now it's something that was from 2011, but I still think it's important to revisit today. So here is a case, and again, I'm just looking at this from the article perspective, and it just made me really think because I'm doing an audit right now that involves residents and a lot of hospital visits and supervising physicians, office visits as well, and residents in the office setting under their agreement. But I think we have to look at the big picture when we look at, first of all, how doctors are burning out on documentation, but then what is the remedy? And it's not always copy paste or using the EMR to their advantage without understanding how dangerous it could be if you are pulling records through. So here's kind of what happened in this. So there was a physician, and he was the first in his family, and he, was always known for being, a great, legendary, actually, undergrad, graduate, had a ton of perseverance, studied more, arriving earlier, staying later than anyone. He was in a pediatric residency, and he realized that he had problems with his efficiency. And as his responsibilities for each day began to grow, he became more overwhelmed with his duties. And on more than one occasion, he said he arrived at his rounds not having seen all his patients or writing the orders or even having checked their labs, because he just found that his breaking point of working 12 to 18-hour days was really about trying to keep up with daily progress notes. That's what took up the majority of his time, many, many hours a day, instead of actually being able to see patients. Then he found that, somebody told him, he was informed that it was commonplace for residents to simply copy and paste the previous exam assessment and plan into the following day's notes, only editing if changes needed to be made. And he said that's interesting because his home institution at the time did not use electronic medical records. Again, this is going back 14 years, but he said he had been unaware that selective editing was possible, appropriate, allowed, or even ethical. He just didn't understand how that could work. But he agreed. He said, okay, I will selectively edit my daily notes. And he, of course, saw his efficiency coming up. But one of the things that we found with EMRs and even with the change in the E&M documentation guidelines, the AMA said we did this so that doctors and providers would have more time with patients, but all it's doing is adding more patients to the schedule. And what happened a short time later is that he said he transcribed some recommendations on the wrong note. He copied recommendations for one of his pediatric patients with staph cellulitis to a similarly afflicted patient who also had renal disease. When the patient with renal disease was written for a scheduled therapy rather than a pulse dose, it caused a rise in creatinine levels, and the patient required a prolonged hospitalization, obviously because there was a problem there. So here's where you get into the modern record, and pulling it forward even now into 2025. It's really tough because the medical record of today, it's not only a clinical record to inform other physicians and healthcare workers of findings, thoughts, plans. It's also a legal document in the event of malpractice claim or occupational injury, and along with support for billing payers for reimbursement, by hospital review committees for quality assurance and improvement. It's also a collection of data for, research and supportive research. The electronic medical record does have many benefits over handwritten entries in a paper chart. I come from old school where I've been auditing providers ever since I had to try to read their notes in a paper chart, hold it up to the light, and see what they were trying to tell me. And EMR entries are always legible. They're typically dated and timed, and the patient information can be available both at the point of care and remotely, which has definitely helped my business being able to work remotely. And some EMR systems include computerized physician order entry and decision support tools designed to improve patient care and safety. So while these features can save physicians time by providing easy access to a massive information, they don't necessarily save time in the day-to-day entry of patient encounter notes. More than 2/3 of internal medicine residents who were surveyed by the AMA said that they spent in excess of 4 hours daily performing documentation tasks, and only 1/3 of the time was actually spent with patients. And there's also a certain restriction on the ACGME work hours. So it's understandable why a resident who's very busy would try to find ways to enter their information in the EMR more efficiently. But the problem that I am seeing, and I'm actually really disdain to even say it out loud, is that efficiency, although important, it can't compromise patient care or even the educational experience, giving shortcuts to our residents and any training physicians. I'm even finding in the recent audit that I'm doing again with a couple of colleagues that providers were completing not only the history of present illness but the assessment and plan the day before they saw the patient. You can't do that. You can't say the level of pain or what your plan is before the patient is physically seen. Copying and pasting of information within the EMR may be a time-saving tactic that medical centers do, and a lot of it's common and it's varied with level of training. You're copying your own notes and pulling it forward. But I'm now seeing it being copied and pulled forward from other providers, and large sections of notes being copied without changes from one day to the next hospital stay. It looks almost exactly the same. And they're being copied forward without adding any new information or edited information. I'm even seeing the patients started off as male, and now in the exam they're female. They go back to male, and I'm not talking about, what I'm talking about. I'm talking about just really bad copy paste, copy forward, cloning, and pulling information if you get distracted into a note that isn't appropriate. And even despite the widespread use of this, copy forward and copy paste, there are a lot of ethical issues that are now being raised. It's been shown to produce notes that are confusing, increasingly lengthy, uninformative, disorganized, internally inconsistent, misleading, or, and the big one, lacking credibility in ways that may introduce and propagate errors that can place patients at risk. As a clinician educator, I am concerned about the loss of a major educational opportunity here. Writing notes or not bringing forward notes is a means of documenting history taking and exam skills and a thought process that can culminate in an assessment, in a differential diagnosis, in a plan of evaluation and treatment. Writing the daily progress notes, and I'm not saying longhand, I'm saying doing it individually for patients, is an important training tool that residents experience and internalize the cognitive processes that constitute medical reasoning and analysis. And it means that they need that for a learner to demonstrate the development of these skills. So how do you deal with this? Who's responsible for this error of not understanding shortcuts at the beginning level of being a physician is a safety concern. It's something that needs to be addressed, especially as I'm now seeing so much AI, so much, added information that it really can be focused on human error and system failures. So the physician definitely, in the scenario I gave you, certainly bears responsibilities for his actions, and including the presumed carelessness that resulted in the harm to the patient. But he was told that the copy forward practice was time-saving strategy. And, copying notes from one patient to the other, he realized that it was actually could be more risky than the original error of basically not getting things done. So, one of the things that I think is really important is you're talking to your physicians about trustworthiness of their medical records. Hospital and medical staff, office staff, clinicians, you need to have the highest standards of patient care and quality, and that includes notes. That includes the integrity. Clinical documentation integrity, CDI, that is not just an acronym. There is a responsibility in the medical record for it to be accurate and to ensure its integrity. That's why I'm an auditor. That's why we are flooded with audits right now. They want to see, are we doing, not just are we capturing what we sent to the insurance company, but are we supporting in the electronic medical record what we actually have diagnosed, what this patient came in for? Are we addressing the problems? And does the documentation meet the standards of integrity and not just the standards of technology? And I think that's where you have to be careful, because copying usually is static information, drug information, lists, demographic information, and previous history. That's fine, because that is independently verified by clinical staff. But somewhere in the process of checking these templated boxes, typing, clicking drop-down windows, cutting, counting, copying, and pasting, we have all lost sight of the original purpose of the daily progress note. And that is to succinctly communicate findings, thoughts, and plans of what's next for the patient. And this is even more vital as physicians' work hours are increasing. And so it's really important to really make sure that your notes in the EMRs, EHR, whatever you want to call it, electronic medical record, is of high quality. It accurately depicts today's encounter of the patient, not the previous encounter. And that if you're going to copy, paste, or pull forward any information, it's only the generic part. It's not today's observations. And I can't say that strong enough, because we are in the era of shortcuts. I feel like everyone wants a remote control for everything we do. But you have to ask yourself, is this ethical? Will this cause a problem with the patient? And is there a safety concern? And you just don't want it to find it on the back end. And it's not just for monetary penalties that could happen to you. It's you want to make sure that your patients are protected, and then legally you are also protected. So keep this in mind today. I just thought this was an important conversation to have with your providers. And if you ever need an audit, or you just want to check and see how your providers are doing, because I know a lot of practices say, well, we use an EMR, we don't need an audit because that basically codes for us, and we can drop and paste and cut and paste and put everything in. Not exactly. Ever since the EMRs, electronic health records, came out, I would say errors on medical records have increased more than the written note. The only thing the written note was a problem is legibility. Now that we have legibility, we've got now these issues with incorrect or unupdated, non-updated records, or cross records that don't apply to the actual patient. So let us know if we can assist. Again, I just felt like this was a topic I needed to bring to your attention today. We haven't talked about it in a long time, and I hope you found it helpful when you're having these discussions with your providers. And always bring it to your provider's attention or your administrator's attention. If you are internally auditing a record and it doesn't make sense, just think, you found one, how many are there that you didn't review that could be also a problem? And now that patients have portal access and they could see their records, this could be a big can of worms if it's not, nipped in the bud right away. Okay, everyone, hopefully you found this helpful. I hope you're having a good January to start off your 2025, and definitely take a look at our website. We have our membership service, and I wanted to shout out to all of our new members from everywhere from Iowa, Indiana, Washington, California, Kansas, Texas. where else did we get just a current one? Another one from Chicago, Pittsburgh. So we have a lot of new membership clients for coding, billing, and compliance questions through email. And you can always find it on our website at terryfletcher.net. Drop down the first screen on services, and we are happy to have you if you would like to join. So make it a great rest of your week, make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.